Okay, yeah, so it should be recording now. Um, I do want to apologize. I've been sick this last weekend, so my voice is a little raspy. So if you can't hear or can't hear very well enough, please just try to move closer because I can't really talk any louder. All right, so talking about this, we're going to be kind of going pretty quickly through the anatomy portion because you're not going to get too many test questions on this. This stuff is important, and you should understand the different portions of the anatomy when we talk about the oropharynx being the mouth, okay, nasopharynx being the nose, the laryngopharynx where your where your larynx begins, and then we talk about different parts of the neck. Okay, this is going to be real important if you decide to go to paramedic school, but it's not super important right now. Understanding everything about the trachea and larynx itself. Okay, we're gonna talk about this more in depth as we go on. All right, so real quick, inhalation. Okay, when you breathe in, how does that work? How do you take a breath? Okay, so you said diaphragm. What does the diaphragm do? So the diaphragm contracts or moves lower. Our rib cage expands, and air rushes into our body. Okay, it's not so much that we are taking a breath. It's a negative pressure system. Okay, this is a negative pressure system, and that's how we breathe. Okay, like it says, it's an active process here. Exhalation, okay, bless you, the opposite of this is when everything relaxes. Our diaphragm moves up, everything decreases in size, and the air is forced out. Okay, so just kind of moving past this. Right here, this is an important part. Some COPD patients rely on a hypoxic drive. Did anybody explain to you guys what a hypoxic drive is? Okay, so COPD patients, okay, we're talking about patients with emphysema here, okay, or some type of chronic obstruction. Hey guys, if you want to have a conversation, take it elsewhere, okay? But COPD patients rely on what's called a hypoxic drive, whereas everybody else is a hypercapnic drive. So that hypoxic drive means when they are low on oxygen, that's when they start to breathe. That's when their brain tells them we need to breathe more or breathe faster. That might sound crazy because you're thinking, well, yeah, we all breathe oxygen. Why is it different for us? Why is it different in COPD patients? Well, in your average individual, they have a hypercapnic drive. What that means is when your CO2 builds up too high in your blood, your brain then tells you to take a breath. That's different from COPD patients. They typically have a very high level of CO2 in their bloodstream because their body relies on a hypoxic drive, not a hypercapnic drive. Yes, in COPD patients, they have much more CO2 in their bloods, in their bloodstream. For us, when our CO2 gets too high, our brain says, hey, breathe more, breathe faster, breathe deeper. This is also another important part. Make sure you understand the difference between these three things. Oxygenation, ventilation, and respiration. All right, oxygenation is when oxygen saturates the blood and cells. It's when it saturates the blood and cells. Ventilation is moving air in and out, which is different from respiration. That's the process of gas exchange. So when we say, hey, I need you to bag this guy, we're really saying, I need you to ventilate this guy because you are forcing air into their lungs and allowing it to escape. Now, in their lungs, at the alveoli, that is where the gas exchange occurs. What is that gas exchange? What two gases, primarily? Say what? Carbon dioxide and oxygen. Okay? Carbon dioxide, what's the chemical name for that? CO2. Okay? So respiration is where we exchange O2 for CO2. All right, moving on. Here's another thing. Hypoxia, okay, let's actually talk about this one first. Hypoxemia. Hypoxemia is low oxygen in your blood. The emia is in the blood, which is different from hypoxia, which is low oxygen in your cells. So hypoxemia can lead to hypoxia. Okay, and there are other ways that you can develop hypoxia: airway obstructions, inadequate breathing, and shock. Those are other ways you can develop hypoxia or become hypoxic. Cyanosis, what does that mean? It's the bluing of the skin. It's a late sign, okay, a late sign. You're not going to see this immediately, so if you do see this in your patients, they need oxygen very badly and very quickly. Here's just some examples of where you might see that cyanosis. This is also super important here. In children, hypoxia may result in bradycardia. Brady meaning what? Slowing, cardia, heart rate. Okay, so a slowing of the heart rate. In children, their heart rate is typically higher or lower than that of an adult. Higher. Okay, it's typically higher than that of an adult. So if they are bradycardic, they are already on a downward spiral. They're on a downward spiral. So your airway obstructions are one of the leading causes of cardiac arrest in children, because they become hypoxic, they become bradycardic, and then they just go into cardiac arrest. So I'm sure you guys have heard before that pediatrics, they maintain for a long time and then they just crash. So that is something to take into consideration, that if you see a child that is cyanotic, like we said, that's a late stage of hypoxia, if they're already cyanotic, they've been struggling for a while. So we need to give them oxygen quickly. All right, we talked about that gas exchange. Where does that gas exchange occur in your lungs? At the alveoli, okay? Those grape-like clusters, okay? And if you go into paramedic school, you're going to learn a lot more about it, okay? But here, just in EMT school, we just need to know that that's where that gas exchange occurs. So, some things that can affect that gas exchange are infection or possibly a buildup of fluid in the lungs. Why might someone have a buildup of fluid in the lungs? Drowning, that's one. So poor gas exchange there. What else? Not so much hemorrhaging, but maybe they have congestive heart failure, okay, which causes fluid to back up, okay, and some of that fluid is going to get into the lungs. What about pneumonia? What's pneumonia? It's a lot of fluid in the lungs. So if we are auscultating, we're using our stethoscopes to listen, they might be diminished or maybe even clear in the upper lobes, but they're going to be very difficult to hear in the lower lobes. Why? Of someone that has pneumonia.
There's no air down or reaching down.
It's covered in fluid. Okay, so we think about gravity, it's going to sink to the lowest spot. So we're not going to have a bunch of fluid in our upper lobes unless they're lying flat. All right. This is whatever. Okay, we talked about this. The gas exchange occurs. Okay, We're going to talk a little bit more about this week when we talk about shock. When we talk about shock and the anaerobic metabolism. So anaerobic, what does that mean? Without oxygen. So when your body is working without oxygen, you move into an anaerobic state because it's still trying to do everything it has to do to survive. And part of that is giving itself energy. Okay? And one of the byproducts of this, I'm not going to go super in deep right now, you're going to get more of it next or this week, is the buildup of lactic acid. Okay? You guys ever been running really hard? Who's done track and field? Okay, just about everybody. Okay, you do track and field, you're out there running, and you just feel, your arms feel heavy. You can feel the buildup of lactic acid. Okay, that's because your body is moving into an anaerobic state. It's due to a lack of oxygen. All right, we talked about this a second ago. Pulmonary ventilation may be impaired by myriad of things. Oh no, I didn't talk about this. I was just talking about the gas exchange. Ventilation. Okay, what's the difference between ventilation and respiration? Ventilation is the mechanical process of moving air in and out. Respiration is the gas exchange. Okay, so we're talking about the mechanical portion of this. Interruption of nervous control. Okay, so some type of damage to the spinal column can cause this. Damage to the thorax, okay, the chest. Increased airway resistance, loss of airway patency, okay, new neuromuscular disease. These are all reasons why the in-out may be impaired. Gas exchange, respiration, can be impaired by several different things. We talked about these just a second ago. We mentioned drowning, okay, some type of obstruction, and here are some other toxic gases, ambient oxygen content. How much oxygen is in the air we breathe right now? 21%. All right, talking about the anatomy still going forward, when we're talking about children, okay, their heads are larger than ours. So when they are lying on their backs, we may have to support them by placing a towel under their shoulders to get their head more in line, okay, well, not necessarily their head, but to get their airway more in line to allow them to more easily breathe. These are some other things we might see in geriatric patients. You're going to get a whole lecture on that, on geriatric patients later on. All right, moving on. So we talk about the airway itself and what we're going to do as, not combat medics, as EMTs. All right, so this guy on the left, what's going on with him? That's severe facial burns, and it looks almost like tar maybe has splashed on his face. Okay, so when we're faced with this issue, someone with facial burns, we have to assume that they may have inhaled some superheated gases, whether it's through their nasal passages or their mouth. What are some signs that might tell us that they have indeed inhaled some superheated gases? What might I see on their face? Soot, okay? What if their nasal hairs are burnt? Their mustache or beard is singed? Maybe there's like a charring around their lips. These are all signs that would tell me that they probably inhaled some superheated gases. So let's say we are called to the scene of a fire, and we have one patient, 34-year-old male, and we ask him his name, hey, what's your name? How you doing? Talk to me. And his voice is very hoarse, very raspy. What's our main concern there? Yes, so he's got swelling going on in his throat, And what is our biggest concern?
Lack of air. Or
That,
constricted.
yeah, that we're going to completely lose that airway. We don't want to lose that airway. So what do we need to do as EMTs? High flow oxygen, okay? Give that guy oxygen. So if he's alert and oriented, an OPA is out of the question, but what else can we use? An MPA, okay? We want to try to secure an airway. But an MPA is going to be contraindicated if we have burns around the nose, okay? This is something to take into consideration. What about this guy on the left? We have some severe maxillofacial trauma. What are we going to do for this guy? We maybe, depending on how much of his jaw is still there, because it looks like the mandible, the lower jaw, is almost completely removed. Oh yeah, we're gonna have to suction like crazy for this guy. All right. Also, an NPA may be contraindicated because if we have any type of damage around the nostrils, okay, around the nose, if there is a fracture here or a basilar skull fracture, we can't use an NPA. It's contraindicated. What's a sign on a patient that tells me that my patient has a basilar skull fracture? Starts with the letter B, and we see it behind the ears.
Battle.
Battle signs. Okay? If I see battle signs, that tells me that my patient has a basilar skull fracture, and an MPA is out of the question. Why? If the cranial vault, if his skull is fractured, and I stick that tube in there, it might follow a path that it should not be following. It should be following the nostrils, right? But it might follow a different path and go into their brain. So it's contraindicated. Basilar skull fracture. Okay, so the base of the skull we know is fractured if we see battle signs. That's the bruising behind the ears.
So on both sides or just one side?
It can be both, it can be one. All right, so signs of an open airway. What's another word for an open airway? Starts with a P. Patent. A patent airway. Okay, we can hear and feel air. Their voice is normal. Okay, like we said before, if we're responding to a house fire and their voice is very hoarse and raspy, that's not a good airway. Learn these, okay, when we talk about upper airway sounds, because we're going to talk about upper and lower airway, and we need to know the difference. Snoring is caused by what? The tongue, okay? Crowing is where the larynx spasms. Gurgling could be from a myriad of different things. Vomit, saliva, blood. And then stridor is a swelling of the larynx. So you're going to see the word stridor a lot. And you may get a question about which of the following is an upper airway obstruction. Stridor is an upper airway obstruction, as well as all of these. Okay? But we're going to talk about upper and lower airway complications. All right, blocked or inadequate airway. All right, these are some reasons. All right, swelling to the mouth or tongue or oropharynx. Swelling of the tongue is angioedema. Angioedema. You might see that term again. If not on your exams, you're going to see it on the National Registry. Angioedema is the swelling of the tongue. There is a blood pressure medication that has a side effect or possible side effect of angioedema called lisinopril. You guys ever heard of that medication? All right, you're going to see it a lot when you start doing your write-outs. Just about everybody over the age of 55 is on some type of blood pressure medication and one of them is called lisinopril. And one of the side effects of it, possible side effects, is angioedema, which is a swelling of the tongue. All right, we open up the mouth in an unresponsive patient and assess the airway. In a conscious patient, what's the easiest way to assess their airway? Talk to them. Okay? In an unconscious, non-traumatic patient, how do we open the airway? Unconscious, non-traumatic. Head tilt, chin lift. Unconscious, traumatic. Jaw thrust. You're probably going to get questions like that. All right, so when we open up the airway, okay, manual maneuvers, we just talked about those. Head tilt, chin lift, or jaw thrust. We may have to suction the airway. And when we talk about mechanical airways, we're talking about OPA, MPA, and then moving on to the iGel. Head tilt, chin lift, we know this. It may be necessary to place a pad beneath the shoulders, especially in our pediatric patients. And here's a good example of that. We need to place some towels under them because their heads are proportionately larger than that of an adult. All right, jaw thrust maneuver when spinal injury is suspected for our traumatic patients. All right, so the jaw thrust. Are we just going to hold this forever? No, that's just impractical. What are we going to do for this guy? We're going to put in some type of airway, okay? And it might be a supraglottic, just kind of depends on what's going to be most beneficial for the patient, because if they have a gag reflex, can we use a supraglottic airway? No. That also rules out OPA. So we could put an NPA in our unconscious traumatic casualties. And if we suspect a spinal injury, what else do we need to put on them? C-collar. Okay? C-collar. Jaw thrust maneuver in infants and children. There's some great photos that show that. All right? Positioning. Positioning might be all that they need to secure the airway. If they are altered, okay, or at risk of aspiration, what's a patient that might be altered and at risk of aspiration? That's a great one. Okay, so we have that traumatic patient that's unconscious and has severe maxillofacial trauma, so he's bleeding a lot. But that guy probably has some type of spinal injury, or we might assume so, because if there's enough destruction to the face, we assume that there's probably some energy, that kinetic energy was passed to the neck and spine. What about a Baylor student coming out of the bar at 2 a.m., drunk, falls down, hits his head? Would that be somebody that has an altered mental status and at risk of aspiration? 100%. Assuming there's no spinal complication, we can put them in the recovery position, which is also known as the left lateral recumbent. They need to be placed on their left side. What if your patient is on a long spine board and they start to throw up? You pick up the entire spine board. Because in your skill, mechanical aids of breathing, what do you do when he starts to vomit? You turn the patient's head and neck. Can we do that with somebody with a C-collar on? No. So we got to move, bless you, we got to move the entire board and then potentially prop it up with whatever we have on the truck so that it remains in that left lateral recumbent position. And then after they vomit, we're going to have to suction the airway. Okay? I want to move down to the photos. Okay, here's something that a lot of people forget about and miss. You should measure the tube that you're placing into their mouth, the Yonker tube. So just like you measure an OPA, corner of the mouth to the tip of the ear, we should measure this. Now, in a perfect world, I take a little piece of tape and I'd mark where that is so I don't go past that. But if I need to suction my patient, is their airway patent? No. So I don't have time to screw around and put tape there. I just have to be careful when I insert it and I don't trigger their gag reflex. How do we suction? Left to right, okay, sucking everything up. We move in that crisscross pattern, backing up out of the mouth. Only apply suction as we withdraw. All right. Moving on. Airway adjuncts, okay, used in conjunction with manual airway maneuvers. All right, we talked about this, OPA and NPA. We already hit that up. Or moving on to an iGel if necessary. OPAs, we know all about these guys. Contraindicated if they have a gag reflex. Okay, contraindicated if they have a gag reflex. The NPA, all right, some patients you cannot use an OPA for several reasons. Maybe they have a gag reflex like I mentioned. Or maybe they have clenched teeth. Why might your patient have clenched teeth? Say what? A broken jaw? Why else? What if they're actively seizing? Are you going to put anything in the mouth of a patient that's actively seizing? No, absolutely not. And if they are going in and out of seizures, okay, we call that, you'll learn this later on, it's called status epilepticus. If they're having back-to-back-to-back seizures, we're also not going to put that OPA in there. An NPA would probably be a good idea. You're not going to find this in the book, but a good rule of thumb is that the diameter of the NPA is approximately the size of the patient's pinky. All right, talking about breathing. All right, so A, B, C's, we know this. We got the airway open. Quick check on learning. What is ventilation? What's the definition of that? The mechanical process of air in and out, and respiration is the gas exchange. All right, alveolar ventilation is the amount of air breathed in that reaches the alveoli. Dead space does not change when tidal volume decreases. All right, so we'll get a little bit more into that later on when that becomes pertinent. Excuse me. All right, so rate, rhythm, and quality. All right, I want to know, how fast are they breathing? Is it a regular or abnormal rhythm? And what's the quality? Is it, and this kind of ties into depth, is it shallow? Is it deep? Is it ragged? Is it agonal respirations? These types of things. So look, listen, and feel, and then auscultate with our stethoscope. And we know that the apex, base is where we're going to listen to. All right, checking for rate, rhythm, quality. Moving on. All right, so when we talk about hypoxia, what did we say hypoxia was? Inadequate oxygen to the cells. And hypoxemia is in the blood. So inadequate breathing leads to hypoxia. If the breathing is inadequate, all right, if we're not oxygenating our cells, the brain begins to die within 4 to 6 minutes. So it is tantamount that we start breathing for these patients. All right, respiratory failure, respiratory arrest. All right, we know what those are, okay? We just talked about this, rate, rhythm, quality. Tachypnea means what? Fast what? Fast breathing. And bradypnea? Slow breathing. Rhythm, irregular patterns. So we're going to talk a lot about different irregular patterns when we get into our more medical portion. That's going to be after trauma. All right. Here we talked about abnormal airway sounds. Stridor. What did we say stridor was? The constriction of the larynx. You might see this word. Sonorous means snoring. And I get it, you know, like it's a lot easier to say like they're snoring, but your national registry is going to have a lot of these medical terms to check and see if you learn these throughout the course. So just kind of having these in the back of your head is a good idea. Gurgling is what? Fluid. What kind of fluid? Blood, saliva, vomit. Okay. What's another word for vomit in the medical terminology? Emesis. Emesis. All right, so here's some more abnormal breath sounds, and some of these are lower airway breath sounds. Strider, when you talked about that one, that's an upper airway. Wheezing. Wheezing. What is wheezing? That's that kind of high-pitched whistle that we hear on inspiration. So when they breathe in, we hear a high-pitched whistle sound. And what is causing that? So earlier in the anatomy physiology portion of your airway and lungs, the bronchioles are constricting. So that's why they are wheezing. The bronchioles are constricting. How do we solve this? Albuterol. And albuterol is going to help with those bronchioles constricting and allow them to dilate. Crackles, also known as rails, okay, is like a popping sound that is heard, and it sounds a little bit like Rice Krispies when you pour milk into the bowl. That sound is the alveoli popping open, because they may be surrounded by fluid, and so that's what that sound is. That crackles or rails, these are both lower airway sounds. Wheezing, crackles, rails are lower airway. Strider, upper. I'm beating on that because I know there's questions on there about the difference between upper and lower. All right, inadequate chest wall movement or a chest wall injury. Paradoxical chest wall. I talked about this, I think, last time during the patient assessment. What is paradoxical chest wall movement? This is where you have fractured ribs. You have fractured ribs. You have a flailed chest. Two or more ribs that are right next to each other, are broken in two or more places. Okay? So what happens is that when I take a breath and my chest expands, that portion will sink in. And then I exhale, my chest contracts, that portion is going to bulge out in a paradoxical motion or seesaw effect. All right, what's going on with this guy? What do we see around his mouth? Cyanosis, that bluing of the skin. Early sign or late sign of hypoxia? Late sign. All right, deciding whether or not to assist ventilation. Ventilation is the mechanical process. All right, so there are times that our patient could still be awake, that we may have to breathe for them. Now, your patients may not tolerate it very well, and they may push the bag away. And if they do that, what are you going to have to switch to? A non-rebreather. Okay? What if they don't tolerate a non-rebreather? Say what? Yeah, we're just going to have to do flow by oxygen, just holding something near their face and hoping that helps. And it may sound messed up, but these patients that are so altered that they won't allow you to assist, you may have to wait until they are worse off or unconscious to start helping them or giving them the help that they actually need, because they just don't tolerate it. So they may be alert but not fully oriented. Okay, so what's the difference between alert and oriented? Alert means that they know you're there. They see you around. They're paying attention. But oriented, they are confused. And we say they are A&O times 4. What are those 4 things? Person, place, time, and event. Okay? Person, place, time, and event. Who are you? Where are you? What day, year, month is it? And what were you doing when this happened? If you get questions like, or answers like, Thomas Jefferson, I'm at Philadelphia, it's 1776, and I just recently signed the Declaration of Independence, those are all vastly incorrect answers. Okay, so they're A&O times 0. But they may just start pushing your stuff away when you have to ventilate for them, and you just got to do what you got to do. Like we said, either switch to a non-rebreather or flow by and just hope that's enough. Or you got to wait until their condition degrades, and then you can start treating them. Okay, so there's significant physiological difference between spontaneous breathing and positive pressure ventilation. So spontaneous breathing is what we are doing right now. Okay, we are in control of it versus positive pressure where we are breathing for them. So some of those differences are going to be the thoracic pressure, the pressure that is built up in the chest, especially if we need a CPAP. And we're going to talk about that in a little bit when we get there. Making a good mask seal, this is very important when we're working on patients. So right now, we have plastic mannequins, right? But in the real world, people have, especially older men, have what on their face? Beards. Beards are very difficult to work with and getting a good mask seal. So that's something to consider when you are ventilating for your patients. Different precautions. All right. Things we want to see. Okay. We want to see their color improve. We want to see their heart rate decrease. Okay. Because when you become hypoxic as an adult, if you're hypoxic, you become tachycardic or bradycardic. Tachycardic. Why? Yeah, your brain's saying, I need you to breathe more, breathe faster. Okay, so you're breathing more, breathing faster, and so your heart rate kicks up as well to disperse that oxygen around your body. But children become bradycardic in hypoxia. Don't forget that. All right, ventilation rate is too fast, too slow. What is the rate that we're going to give these people? We're breathing for them? Once every 6 seconds. All right. This is talking about mouth to mouth or mouth to nose. All right, we're going to kind of skip past this. Bag valve mask. All right, so the BVM is a great device because it's going to allow us to get a lot more oxygen in there more regularly, okay? And it's going to be high flow oxygen as opposed to us breathing for them here. All right, so we know how to apply it. We know what we're doing, that EC technique. If you're using 2 rescuers, this is ideal because you have 2 people applying that mask. And this guy has what? He has a beard. All right, so using 2 rescuers is going to be advantageous for this type of person. What if they have all that Duck Dynasty? You know what I'm talking about? A gigantic beard? Okay, you're going to be struggling if you're by yourself. So 2-person rescue right there would be advantageous. All right, no chest wall movement, that rise fall. Okay, this is what we're going to have to look for. Head position, we're going to reposition the patient. Do another head tilt chin lift. Maybe an airway adjunct might be necessary. Assess the mask seal, that EC technique. Check that. Or maybe they have just too big a bushy of a beard and it's very difficult. Airway obstruction. What types of airway obstructions might we have that could affect chest wall movement. Food, yeah. Yeah, do you have a question?
If you were by yourself, could you shave his beard?
You could try, but you're not really gonna have. I mean, almost impossible because you're not gonna have those like resources to do it. So you should have an not electric. You should have a surgical razor in your kit, multiple. But that's really just for the chest. We don't really want to do that to the face. It's gonna be very difficult to remove that hair because you're gonna have to remove a lot to get a good seal.
Wake up with no hair.
Say again?
Come on, buddy. Wake up with no hair.
Well, at least they're alive. All right, inline stabilization during bag valve mask. All right, so this is that person there at the head. Okay, they're using the EC technique and ventilating. Here's somebody stabilizing C-spine while the other person is ventilating. And here we have two-person rescuer. All right, a FROP VD. You're probably not going to see this, but this stands for Flow Restricted Oxygen Powered Ventilation Device. Okay, and this is a FROP VD. So it's only used, well, you really only want to use it for the no suspected spinal injury. You can use it on if they do have a spinal injury, but it's just a lot more difficult because you have to hold their airway open. And how do we hold their airway open if they have a suspected spinal injury? Jaw thrust. Okay, so it's a lot more difficult. All right, automatic transport ventilators. You may or may not have these in the truck. Okay, I know AMR does not. But here's an example of the ventilator. And if you don't know how to use it, it's also not very, it's not good. Not knowing how to use your equipment is, you're setting yourself up for failure. All right, so we're not really talking about ATVs too much, but we are going to talk about CPAP. All right, because this is something that, as EMTs, we should definitely know how to use it. What does CPAP stand for? Continuous positive airway pressure. Outstanding. All right, so what is this guy doing? He's auscultating. All right, why is he auscultating? So why do we put a CPAP on our patients in the first place? Because they're in respiratory distress. All right, they're in respiratory distress. Why are they in respiratory distress? We may not necessarily know, so he's trying to figure it out. So he's listening to lung sounds. What are some lung sounds we might hear? I talked about two of them earlier. One starts with a W, wheezing, and the other is rails, crackles and rails. So those are the same thing. Wheezing is the bronchioles constricting, and what is crackles or rails? That's the alveoli popping open. All right, here's one on a child. This is a great photo, okay? So the child, just look at them real quick. What do you see in her face? Just drained. She's tired, okay? When you put a CPAP on a patient, actually, let me back up. One of the reasons to definitely put a CPAP on a patient, assuming they meet all the indications, is if they do have that just drained and tired look. They are just going to be crashing. They're going to get worse and worse and worse unless we start doing something for them. Maybe we don't have to ventilate for them, but a CPAP is going to be a good idea here. This is perfect in a patient that is just kind of fading out. They're fading fast, and we got to do something for them. Contraindications to CPAP, what are they? Systolic blood pressure under 90 millimeters of mercury. What else? They're actively vomiting. Say what? They can't protect their own airway. And they can't sit up on their own. And they have to be alert and oriented. Okay, that's a bit. That one's kind of a iffy. That's what it says on your skill sheet. But they kind of, once they're looking like this, that alertness might be fading a little bit. All right. So, what does a CPAP do? So the CPAP is going to increase the intrathoracic pressure. Intra meaning inside, thoracic, okay, chest pressure, right? We know what that word means. It's going to increase the intrathoracic pressure. One consequence of that is that it causes a lower or decreased blood pressure. It can cause decreased blood pressure. So if my patient has a systolic blood pressure of 80 millimeters of mercury, which we know is a contraindication, why should I not put that CPAP on them? Because it's probably going to lower it even further. Okay, and it might cause them to be what do we call low blood pressure? Hypotensive or tension. They're hypotensive. And we do not want to cause that. All right, so here it talks about titrating it. On your skill sheet, what do you set the CMH2O to? The centimeters of water. What do you set it to? Between 6 and 10. All right. Start at the lowest setting, work your way up. Here's another good one. And this is protocol based, okay, restrict CPAP to the age of 12 or older. Probably not going to get a test question on that, but just kind of keep that in mind. All right, so moving on. Indications for CPAP. These are some big ones right here. Congestive heart failure, CHF. You're going to be using that a lot. Okay, your patients with CHF, they oftentimes have a lot of difficulty breathing because their heart is it's failing. Okay, so it's all that starting to back up. Okay, pulmonary edema, COPD, which is a chronic obstruction pulmonary disorder or disease, asthma or pneumonia. All right, quick check on learning. COPD, what type of drive do they have? Hypoxic drive. What do we have? What type of drive? Hypercapnic drive. Hypercapnic. Because when our CO2 gets too high, our brain tells us to take a breath. All right, contraindications, we just went over these. All right, so moving on. Still talking about the CPAP. All right, there's also a BiPAP out there. It just allows you to set, so CPAP it's just continuous, okay? It's the exact same amount of pressure in and out. BiPAP will allow you to change it for inspiration and expiration, inhaling and exhaling. There's high flow nasal cannulas. Okay, you're not going to get those on the truck. You're going to see those in hospitals. Hazards of overventilation. All right. In cardiac arrest, perfusion is decreased. Also, overventilating our patient, if we're too aggressive, what can happen, to the stomach? Full of air. What do we call that? Gastric. Starts with a D. Gastric distension. Gastric distension. All right, you're probably going to see a test question about stomas or tracheostomy tubes. All right, stomas. This is what they are. This is what they look like. All right. We can ventilate a patient over their stoma. If they have a tube, we can hook up if they have a tube, we can hook up a BVM to it, but if it's just open like this, we can place the BVM directly on top of that. I think there's a photo. All right, here's a photo of us attaching a BVM to the tube, okay? But if it's just open, we can place the mask directly over that site. So, do you think you would want to use an adult mask or a child, a pediatric mask for a stoma? Pediatric mask. Pediatric mask.
Are those common or no?
What? Stomas?
Yeah.
I've only seen one. But it's just something to take into consideration there. So you might get a test question that says something along the lines of you have a patient with a stoma and they're experiencing difficulty breathing, what's one of the first things you should do? And that is to suction their stoma. You want to suction it. You want to suction that stoma. Clear, suction the stoma. Boom, right here. All right, so you've seen it. Especially if you're going to ventilate your patient with bag valve mask, you want to clear and suction the stoma before you start ventilating. All right, mouth the stoma? Okay. No, thanks. It says you must use a barrier device. It's not happening. I'm not doing it. All right. Using the BVM, okay. Avoid excessive volumes of pressure, all right. And we want to make sure it has a pop-off valve, which all modern BVMs have. Okay, they should have it. All right, I talked about this earlier. When opening the airway of an infant, okay, we can do the head tilt chin lift or the jaw thrust in an infant, and it's a little more difficult because they have a lot more. Everybody knows babies got those big chubby cheeks. Okay, they're just kind of little roly polies. Okay, look at this. There's a lot of just adipose tissue right there. All right, it's in my opinion a lot harder to do a jaw thrust on an infant. With a child, it's pretty similar to an adult. All right, sizing BVM on a pediatric patient. We know what we're doing here. We've all done this before. All right, foreign body airway obstruction in adults and children. FBAO, foreign body airway obstructions. All right, so if they are conscious and they are alert and oriented and an adult and they are showing the signs of choking, what do? I'm an adult. I'm giving you the signs that I'm choking. The Heimlich maneuver, okay? But they're not going to call it the Heimlich maneuver. They're going to call it like an abdominal thrust. Okay, abdominal thrust. What if I were a pregnant woman? I'm 8 months pregnant and I'm choking. What do? Chest thrust. Chest thrust. You go above what's called the fundus, which is the child. Okay. For infants, pediatrics, we alternate. Well, for infants, we alternate between back blows and chest thrusts. And you guys are going to go real into this on your when you guys do CPR. Who's CPR qualified? I know some of you guys said it already. Yeah. So when you guys do your CPR class this week, you're going to do that for pediatric or infants right here. Back blows. Okay, so between the shoulder blades, 5 good hearty thrusts. Okay, because you're trying to get rid of that obstruction. Here is a abdominal thrust on a child. They're responsive. All right, when they go unconscious, we immediately start doing compressions. Okay, for adults and pediatrics, when we're by ourselves, 30 to 2. Okay, 30 compressions to 2 breaths. And before we give that breath, what are we going to do about the airway? We're going to open it and look for the obstruction. If we see the obstruction, get it out. Do we do blind finger sweeps? No, do not do blind finger sweeps. All right, dental appliances like dentures, okay, sometimes they can be loose. Okay, if they're loose, just remove them. Now, this is a consideration. Using your BVM is is easier when they have their teeth in. When they take their teeth out, they lose a lot of form to their mouth. Okay, so it's more difficult to bag somebody when their teeth are out. You're probably going to get a test question like this, calculating the amount of oxygen that's left. Guys, I'm no help to you, all right? But you may get a test question about calculating how much oxygen is left. If you know it, you know it. I just guessed because I couldn't remember the formulas. It talks about how we store it, pressure regulators, okay, humidifiers, This is probably less about what we need to know. Okay, oxygen administration. We know all this. This is part of our skills. Okay, still, this is all stuff that we talked about in our skills. Oh, real quick. Nasal cannula. What is the flow rate? No. No. 2 to 6. Nasal cannula. 2 to 6 liters. 2 to 6 liters per minute. You're probably going to get a test question like that. There's also the Venturi mask. Don't worry about it. You're not going to see it. Here's just a simple face mask. This one has a bag. Why is it important to get this bag full of air? What if that bag is not full and it's just crinkled up due to moisture or something like that? They're not getting oxygen, okay? This bag needs to be inflated. This is that Venturi mask. Again, don't worry about it. All right, case studies. We're not going to do these. All right, so that's going to end this. Let's take a break, and when we come back, we're going to hit up